everyone. My name is Hartmut Goldschmidt, and I am the president of the GMMG study group. I would like to thank the International Myeloma Foundation to invite me to present our data from the HD7 presented at the ASH meeting 2024. You can see on the next slide the disclosures of our co-workers, and in the next slide, the study design. And you can see here we have 2-2 design, and we presented at the ASH the results from the part 1. And you can see here in this part, we have a standard of care. It's called Revlimid, bortezomib, dexamethasone in the short situation RVd. And in the experimental arm, in the induction treatment in the part 1, we used the CD38 antibody isatuximab in combination with RVd. The induction treatment where 3 cycles are 6 weeks. This means 18 weeks. It's a very long induction treatment. Then we collected stem cells. We performed transplantation. And after transplantation, we have a second randomization to analyze the impact of Isa in combination with lenalidomide in the maintenance part. We have powered the study of MAD negativity. We used flow 10 to -5. And the second question in the induction was to analyze the PFF after second randomization. And then you can see secondary endpoints is overall survival, the PFS of the rule study, and we have looked at the remission rates and also in the MAD negativity rates. In the next slide, you see the flow of the patients. We randomized 1-to-1 662 patients. Half of the patient population were treated with RVd, means lenalidomide, bortezomib, dexamethasone, and in the experimental arm, we have the combination of isatuximab with RVd. The number of patients after the induction treatment was very high. We have around 94% after Isa-RVd and around 89% after RVd. This means that the tolerability of the treatment was very, very good. Then the MAD negative rates that we have seen in the trial. First, we presented the MAD negativity here and post-transplant in this picture. You can see in the column with the blue signature, we have around 60-62% MAD negativity after RVd and transplantation, and we have 47% MAD negativity after RVd and transplantation. If you look at the patient in CR and very good partial remission, the MAD negativity was also in positivity related to the addition of isatuximab. In the significance, the p-value was in all these 3 columns very, very high. Then we look at the very important slide. This is a PFS from the first randomization, and you can see after the induction with 18 weeks treatment with RVd or Isa-RVd, we have a benefit for the patients treated with the antibody in the induction phase. And this results in the reduction of the PFS in around 30%, the risk progression or death after this first randomization. This is a clear benefit for the 4-drug combination compared to the 3-drug combination. Then we look at these PFS subgroups, and you can see in the majority of the subgroups, the benefit for the combination of isatuximab plus RVd, it's significant. And here in the next slide, we have the summary, the addition of the CD38 antibody isatuximab to RVd during an 18 weeks induction followed by autologous stem cell transplantation without consolidation is resulted in an impressive reduction of risk of PFS or death compared with the standard of care RVD, regardless of maintenance therapy. The PFS was observed across clinical relevant subgroups, was seen in all these groups. Isa-RVd is the first regimen to demonstrate a deep and rapid response reflected by MAD negativity and also by a PFS benefit. The autologous transplantation as standard of care for newly diagnosed fit patients up to the age of 70 years in Germany is possible and was similar in both treatment arms. And therefore, the combination of Isa-RVd, RVd, followed by autologous transplantation is safe. And this is what we do now. We have the second randomization. We have done all the part 2 randomizations in the last 2 years. And we're comparing Isa-RVd, lenalidomide versus lenalidomide. The trial is ongoing. We will look at the primary endpoint for the part 2. That would be the PFS from second randomization comparing maintenance therapy with either lenalidomide or lenalidomide alone. And at least I want to thank all our co-workers. I want to thank all the patients. I want to thank all the study teams. They are part of this trial. And at least I want to thank for your interest. Thank you so much.